My name's Lisa Rodrigues. I started my NHS career in 1973. Half of it was spent as a nurse and a health visitor, and then the latter half as a manager, 13 years as a chief executive. I was released into the community last summer, and now I'm a writer and a campaigner. I'm also a patient. I first saw a psychiatrist when I was 15, and I've had mental health problems off and on since. And so you wouldn't be surprised that I'm going to ask a question that is related to the announcement yesterday about zero suicide policy. Deputy Prime Minister presented the policy, and people seem to think it's an interesting idea. People like me, who sometimes consider suicide, are very concerned about it, and we're concerned about it for a number of reasons. I'm going to pose my question. I know you said to one person, but sorry, it's to all of the panel. They can make a choice about whether they answer it or not. I hope all of them will answer it. I'm not pointing it in the direction of a member of the government on the panel, because I don't think that's fair. So it's a laudable aim, but mental health has huge, huge stigma. It starts with stigma that we have within ourselves. That stigma can disappear when you're well, but when you're poorly, it comes back, and it comes back big time, sometimes with voices from somebody else, often with your own voice saying you're not worth it. Then the stigma is family and friends and people you work with, and then the stigma is society and what society is made up of, which includes public services and includes the NHS staff, but also NHS managers. And the impact of that stigma then is really very bad because, as we've been hearing earlier, and I'm really grateful for other people mentioning mental health, we don't spend enough on research. We don't spend enough on services. The status of services is low. The status of staff is not where it should be. Morale of staff is pretty poor at the moment because people are absolutely up against it. The commissioning decisions are discriminatory. Commissioners are often third or fourth in line and don't get to go and speak at the table. So it's physical health versus mental health. Actually, it needs to be all of those things. And Norman, you mentioned reduction in the amount of resources available. It's a real terms reduction. Peter, you also mentioned it too, of around 1% from 12% to 11% of spend. We need to spend about 25% on mental health services because it's about 25% of the disease burden. And that cut in spend on children, young people services has been the most severe over the past 5 years, and yet that's where we've seen the greatest growth in demand. So this stigma has really, really serious implications. I absolutely agree with Sir Bruce that prevention is better than cure, but we don't cut cancer services just because we've reduced smoking. And yet, mental health commissioners are asked to reduce mental health services if we're going to be providing primary prevention. And the one doesn't equate with the other. You don't stop somebody from getting schizophrenia by providing well-being classes or mindfulness classes. You might improve their circumstances, but you don't make that reduction. So the worry that those of us who experience mental health services have about this zero suicide policy is that the impact could be that it sends people further and further away from seeking help. It also means that there'll be another stick to beat services with at a time when they're already right up against it. So my question to the panel is, what are you going to do personally about that, each of you? Thank you.
Thank you, Lisa. Mark Porter, as succinctly as you can, please.
It's fair to say that I don't organise the NHS. I'm absolutely with you and will argue with that. We argue to that end, and I applaud the government for its announcement on this. And there's no two ways around it. When the government does something right, it's important to say so. In a sense, we're prisoners of our past on this. We've had mental health services that have been segregated off because hundreds of years ago we had a silo that was segregated off, and we fought for, okay, we haven't bothered to fight for hundreds of years to try to reverse that injustice. And it's absolutely important to recognise that there should be nothing in principle separating out and indeed stigmatising those services. I think one other thing to say, though, is it's important to bear in mind that while it's often said that other services aren't being cut at the moment, for example, cancer services, do you know what? It's been announced only a few weeks ago that they're going to be, because the Specialised Services Commissioning tariff for next year is proposed to be cut to 50% for any activity over and above last year's total. Specialised services mean things like many cancer services, renal transplant, cardiac, liver, various other services that are currently commissioned outside normal district general hospitals and brought together in regional centres. And the proposal is to cut the tariff price for any activity over and above the previous baseline. So I'm absolutely with you in that what we need to do is to reverse literally centuries of neglect. In that regard, it predates the health service by a long time. But we shouldn't forget that all parts of the NHS are being actively cut at the present.
Thank you. Bruce, briefly.
So I agree with you. And stigma and indeed prejudice are big issues, but stigma is a significant one. If I wind back to when I was younger, my mother had cancer, nobody was able to talk about it. You know, it was a no-go zone. And we've got over that with cancer. We can get over it with mental health. I'd support Mark's comment that years ago, asylums were built here and hospitals for physical disease were built here. And the end result of that was a feeling that somehow or other in both scientific, clinical, and social terms that they were different. Actually, but they weren't. And then the asylums were shut and people were moved out into the community, something we haven't achieved quite so well in physical health. But the science has now advanced. And what the science is showing is a much greater relationship between physical health and mental health. And that's bringing clinicians into a place where they're seeing them as the same thing. And that started the process. And one other thing I'd say, there's been a talk about the relationship between politicians and the NHS. And I'd like to just pay Norman huge credit, because Norman is on our back the whole time saying, what are you doing for mental health services? So the particular things we're doing are we have now a waiting time target for people who are having psychotic episodes. That's really important. And I've seen problems with someone in my family who just couldn't get help from the NHS. We've started a major focus across the country on liaison psychiatry, and we're focusing on this on a really evidence-based therapies of cognitive behavioral therapy. And that's been, I mean, Norman has been tremendously supportive and kept the pressure on there. So I think we're starting to make some progress, but there will be some organic growth in it. It's not something we can solve overnight.
Thank you. Julie Manning.
I was 22 when I was first told that I was mentally ill and needed to see a psychiatrist. And I went home and I sat in the bath and I sobbed and sobbed and sobbed, because my symptoms were extreme fatigue, joint aches, muscle aches. They were all physical symptoms. And no one took the time to explain to me that, you know, mental illness has physical symptoms. And over the years, I've felt more and more that we have this false divide between physical and mental health. It's actually incredibly harmful separating off mental health, because just about every physical condition has a mental component, and a lot of mental health illness has physical symptoms and physical manifestations, and it's really unhelpful for the individual, for society, for understanding, for destigmatizing, to go on talking about mental illness, although I quite understand there's a transition to get to a point where actually we're talking about something else, and whether that should be neurological or brain or whatever it is physical, it's measurable, it is not, you know, in your head and something ephemeral. So I am absolutely with you. There is false division. What we're doing is we've got a report coming out on depression in the next couple of months, and we are talking about parity of esteem, we're talking about stigma, and one of the things that we're highlighting is that medicines for people with mental illness are disincentivized for two reasons. One is that the organization that assesses what medicines should be available to the public, which is nice, rarely, and not ever, actually do a formal assessment and produce a recommendation on medicine for mental illness. So medicines that go to NICE are just given guidance, which means it's optional, which means that no one has to prescribe it. And the other disincentive is that because so few medicines actually come through for mental illness, the difference between the cost of a new medicine and what's already on the market is huge. So, it falls through both gaps in terms of a NICE assessment and making it available to the public. So that's one of the things that we're highlighting. And finally, our last piece of work that came out just a couple of weeks ago was around the concept of head of well-being in state schools. And a fundamental component to that is picking up on the emotional and mental needs of teenagers and actually coordinating. There's a lot of siloed initiatives in schools about physical health, eating, and PE, and PHSE, and citizenship. We think if there's a strategic approach to health and well-being amongst teenagers, that we could actually make a lot more progress and do some of that preventative and supportive work that could be done.
Thank you, Julia. Norman.
Well, I totally support that idea. 3 points. First of all, on this great divide between mental health and physical health. We have a situation where people with severe and enduring mental ill health don't have their physical health needs properly looked after, and so consequently they die about 20 years too early, which is a scandal. And we don't ensure that the mental health needs of people with physical conditions get properly addressed. So, and there's some fantastic work underway with people like Andre Tiley, a psychiatrist in London, who's applying the sort of IAPT psychological therapies to people with heart conditions and getting amazing results. So we need to join the two up together. The second point about the waiting time standards that I've sort of pioneered and pushed through and finally secured starting in April. I bumped into Mike Richards recently, who is now the Chief Inspector of Hospitals, but was the cancer czar under the previous government, and he drove through the waiting time standards in cancer care. And he said to me, Norman, the introduction of standards, access standards in cancer care, transformed cancer treatment. It forced the whole system to think afresh about how people got access, and it can do the same for mental health. So I'm very excited by this. We have to roll it out across the whole of mental health over the next 5 years, but I think there's a fantastic opportunity to achieve genuine equality, because it will force commissioners to take mental health as seriously as physical health. Finally, on the suicide thing, I take a totally different view. I think the fact that, whichever party it is, the fact that the Deputy Prime Minister of our country talked about suicide in the run-up to an election is the most fantastic breakthrough. It would never, ever have happened. We've made a breakthrough with the public discourse about mental health, but the last taboo, in a way, is about suicide. And to get it out into the open and to discuss it is the first, I think, incredibly important thing. I've been driven in my exploration of this by, first of all, extraordinarily inspiring work in Detroit, where Ed Kofi, a really inspiring leader, challenged the assumption in services that a certain proportion of people will take their own life, and said every loss of life is preventable. That had to be the whole principle that everybody signed up to. So this was no target imposed from Whitehall, and this is absolutely not what we're saying. It's about inspiring organisations to think about how they can prevent suicide and regarding every suicide as potentially preventable. And they achieved the most remarkable change, 75% reduction in suicides. They went for over 2 years without a single suicide in Detroit, a pretty distressed city in the United States. Now we've got the most inspiring leaders in our own country. So Joe Rafferty in Merseycare leading the way, getting his organisation to think in the same way. Adrian James, an inspiring psychiatrist from Devon, having a whole county approach to achieving an ambition of reducing suicide to zero. Of course, we recognise that you don't ever get there, but if you think about the principle of saving every life and looking at what went wrong in every case where someone has taken their life, Fascinatingly, Lewis Appleby, who we've worked very closely on this, who's the leading expert in this country, he says that every suicide he has looked at, and there have been very many over the years, he can see things that could have been done differently that would have reduced the risk. So I think this is a really exciting moment. And in a sense, the challenge is just to organisations to be ambitious, to think differently, and in a way to challenge the stigma of mental health, and to think that a life lost through suicide is just as awful as a life lost unnecessarily through cancer. I think it challenges the stigma that you talked about earlier, and so I'm incredibly enthusiastic about it.